Welcome to today's webinar, Translating Science into Better Patient Care in the ICU. Tom Stelfox from the University of Calgary will be presenting today, but I'd like to go through a few housekeeping items and some information on the network news. Today, the Q&A session will follow the presentation, and if you could please submit your questions online during the presentation. We have Perry Kim, our Manager of Research in IP, who will be hosting the Q&A session, and he will try to summarize the questions at the end of the session. A survey will pop up on your screen after the webinar. We would love it if you could give us some feedback so that we can improve our webinar series. And you'll see on the screen that the webinar slides and the video are available for viewing, usually within 24 to 48 hours. Upcoming webinars, you'll see the URL for where you can register, and we hope that you can join us. The next one is July 12th with Jacoby Elliott and Paul Stoley. On July 26th, we have Michelle Howard, and on Wednesday, August the 9th, we have a combination webinar with toilet relocation and wearable caregiver posture coaching feedback system. Just to let everyone know the update on the interdisciplinary fellowship program. The applications were due June 2nd, and we are in the review process. We're just coming to the completion and selection phase now. We will be actually letting everyone know probably mid to late July who is going on to the second selection process, and we'll have a call with everyone to go over the details and ensure everybody still wishes to continue. Please visit our website for details on our HQP program. They cover the HQP in the projects as well as the summer students and the fellows. And we are in the process of doing a needs assessment to further develop the HQP programming. We also have a knowledge translation competition out right now, and the intent to apply is due July 24th. Please visit our website for more details. And stay tuned. We have a new competition coming out, hopefully late summer, and the details will be widely communicated, and they will be up on our website when they're once we've launched. And today, I have the pleasure of introducing Tom Stelfox, who is the Associate Professor of Critical Care Medicine and Community Health Sciences at U of Calgary. He's the Scientific Director of Alberta Health Services Critical Care Strategic Clinical Network. He received his PhD in Healthcare Policy from Harvard University and his MD from the University of Alberta. His research focuses on application of health service research methods to evaluate and improve the quality of healthcare delivery to critically ill patients. Now over to you, Tom, to begin your presentation.
Thank you very much, Carol, for that very nice introduction. I appreciate it. So thank you very much for this opportunity. There we go. I have no disclosures or conflicts of interest, but I do have many acknowledgements. And I really have one objective I'd like to cover over the next sort of 35 to 40 minutes maximum, and that's to tell you a story of knowledge translation. And this is going to represent work that's been done over the last 3 to 4 years. It's been presented in various venues, pieces of it. So if you've heard some of this before, I apologize, but hopefully there'll be pieces in here that are new and of benefit. And I'm going to do this in 3 phases. The first is I want to share with you a patient case just to ground us in the clinical reality of knowledge translation. I then want to sort of briefly review knowledge translation, the why, the where, the when, the how. And then I want to illustrate one applied example from one health system here in Alberta. So this is a very personal reminder for me why knowledge translation is important. So on the morning of April 15th, 2014, as I was walking into the hospital, I received a text. It came from my brother. It was a picture of my sister-in-law and their newborn daughter. This isn't her, but it was a picture like this. I knew that she was due around this time, and so I responded congratulating my brother and my sister-in-law and just sort of saying, let me know when's a good time to give you a call to chat. I'm sure you'll have a busy day. I then went on with my day, had a regular day at work, and then as I was walking into the house at home, my phone rang. It was my brother, and I asked him how things were going. He said, well, it's actually been a bit of a challenging day. And I said, oh, I was a bit surprised. And he said, yes, do you mind speaking to the obstetrician? And I said, sure. So the phone was passed to the obstetrician, who explained to me that my sister-in-law had experienced a large postpartum hemorrhage. She'd been transfused with several units of blood, had been taken to the operating room for an examination under anesthesia. They couldn't find the source of the bleeding, so they presumed that this was likely an atonic uterus. They'd inserted a balloon tamponade device into her uterus, inflated it, felt that they had controlled the bleeding, and she'd now been brought back to the labor and delivery floor, where she was going to be observed for the next 1 to 2 days. I asked the obstetrician some questions, thanked her for the care she was providing my sister-in-law, and the phone was passed back to my brother. I chatted with my brother for a couple of minutes, and then he said to me, Tom, he said, I just don't understand what's going on. And I sort of interjected saying, yes, I understand. He's an engineer. And I said, you come in the hospital for what's supposed to be a regular event in life, and you have this unexpected event. He said, no. He said, since coming back from the operating room, my sister-in-law hasn't really woken up. She's lying in bed. She's kind of in and out of consciousness. She's attached to a monitor that says that her heart rate's 140 and her blood pressure is 70 on 40. I was dumbfounded. I'd just spoken to the obstetrician 2 minutes earlier. I asked him, who's in the room with you? He said, no one. I said, step out of the room, find the nearest person that works in that hospital, tell them you need their help immediately. I'm coming. So my brother and his family live in Edmonton. I live in Calgary. It's a 3-hour drive. So I got into our vehicle and I started to drive. And 3 years ago, we had kind of a newer vehicle and had this hands-free communication system that I think just about all vehicles have these days. And I never understood the value of that technology or innovation until that night. Because during the 3-hour drive from Calgary to Edmonton in the rain and it was dark, I was able to first call an intensive care colleague in Edmonton and ask him if he could find someone who was working at that hospital to go check in on my sister-in-law. I was able to get a hold of my parents who were away on vacation to tell them what was happening, get a hold of my sister, and then I received a phone call from the obstetrician when I was about 30 minutes out of Edmonton. She explained to me that my sister-in-law had gone into hemorrhagic shock, that she'd been taken emergently to the operating room where she'd undergone a total hysterectomy, that they felt they now had control of the bleeding, that she was being transferred to the recovery room to see if she could be extubated, that she'd received a wonderful resuscitation from the anesthesiologist using this brand new medication, which on your screen you can see called Voluven. It's a hydroxyethyl starch product. I didn't mention to the obstetrician that 1 year prior to this, the FDA had put a black box warning on the use of this medication in critically ill patients because it was associated with increased mortality, severe kidney injury, and risk of bleeding. I asked the obstetrician a few more questions, thanked her once again for her care, and then I continued on my journey. I arrived at the hospital about 30 minutes later, went to the intensive care unit. My sister-in-law had already arrived there. She had been extubated, so her breathing tube had been taken out post-operatively. She was in the room there. I saw her. I informed the bedside nurse that I was going to be spending the night at the bedside. The nurse went to say something to me, but didn't. I'm assuming she was going to say something along the lines of, well, our hospital policy doesn't allow family to sort of spend the night in the room, but she didn't, so I really appreciated that. I pulled up a chair and I just sort of watched my sister-in-law over the rest of the night. And you can see we provide wheelchair access to the stairs. And so when I think about opportunities for improvement in my sister-in-law's care, 3 things jump out. The first is there was probably an opportunity to provide better recognition and response to the severity of her illness. And I'll be honest, that's kind of a challenging issue because it's actually not as simple as one might think. I'm an intensive care physician and I'm trained to do this, but not all physicians do this on a day-to-day basis. The second opportunity was to sort of de-adopt a potentially harmful practice, like the use of hydroxyethyl starch, and adopt a potentially beneficial practice, like, for example, effective communication techniques during transitions of care. And then lastly, I would say there's an opportunity to implement patient and family-centered care, although to be fair, this happened sort of 3 years ago. And what we're going to focus on really for the next sort of maybe 25 minutes or so is this middle concept, right, of translation, which is de-adopting harmful practices and adopting beneficial practices. So a brief review of knowledge translation, the why, the where, the when, the how. And I'm going to mainly do this through a critical care lens from a clinical context. So I would say, or I'm going to posit, that I think research should inform clinical practice and potentially through 3 simple mechanisms. The first would be through discovery. And we're going to use the example of ST elevation myocardial infarction. And we can think of, for example, the discovery of streptokinase, the use of thrombolytic therapy to open those coronary arteries in patients with these acute problems. And that would be a new discovery or a new practice. Another way would be for replacement, and that's that as science advances, we have a practice update. So we have new generation medications that have got a better efficacy profile and maybe a better safety profile. And then the third way would be through reversal. And that's when our science ends up illustrating that something that we thought made sense is either ineffective or in fact even harmful. And a nice example would be the use of flecainide and ecainide, which were used to suppress abnormal heartbeats after myocardial infarction. Kind of makes sense, right? But when that was tested in the randomized controlled trial, it turns out it actually resulted in increased risk of death. So what we're really talking about here is a very basic concept, and that's an evidence-based medicine. And I think it's nicely illustrated by the late David Sackett, who is really an international champion for this concept, where he described it as the conscientious, explicit, and judicious use of current best evidence in making decisions. And then he went on in his BMJ article to make the following points, which I think are really nice. He said, good doctors use both individual clinical expertise and the best available external evidence, and neither alone is enough. Without clinical expertise, practice risks becoming tyrannized by evidence. Without current best evidence, practice risks becoming rapidly out of date. And so the challenge that we're really talking about here, I like to think of in terms of sort of either a voltage drop or a waterfall. So if you look at this figure, when we do science and we have organizations around the world that invest tens of billions of dollars in research, we start with tremendous potential in the upper left corner with our discovery research. And then progressively as we move into the clinical world and then into implementation and then ultimately to sustainability and impacting patient care, we end up with a trickle of that effect coming through. And some of that is to be expected because not every discovery in a lab is going to turn into effective improvements in patient care. But what we want to do is minimize the voltage drop as we move along that waterfall. And so I want to just share with you one sort of conceptual model for thinking about this. And so this is Ian Graham's knowledge to action cycle that probably many of you are familiar with. But let me just briefly highlight it. And this is one way of thinking about knowledge translation as an approach to facilitating research use. And so in the center, we've got knowledge creation, which is that inverted triangle. We have a bunch of knowledge that's being generated. It's then synthesized using things like systematic reviews or other synthesis methods. And then we end up with products or tools for knowledge, things like clinical practice guidelines, for example. And that's great, but then what we need to do is get that into practice. And that's what the outer part of this figure shows. So we need to identify the problem. We need to adapt that knowledge to our local context, figure out what are the barriers and facilitators to using that knowledge, then develop and tailor interventions, monitor that actually knowledge use changes, which is great, but then we want to make sure that outcomes are also impacted. So we want to evaluate outcomes, and then ultimately we want to make sure it's sustained, because like many things, we have a problem with decay, where we can drive change, but often that change decays over time. And so as an intensive care physician, I think of this concept very basically. I think of it, first of all, in three buckets. One is underuse. This would be the concept that when science shows an intervention is effective, but it's not used. And I think a nice example in my clinical field would be venous thromboembolism prophylaxis, right? So blood clots that form in the big veins of our legs, pelvis, even our upper extremities, from stasis, and then potentially can cause obstruction or break off and causes bigger problems by going to our lungs. And so we have very strong evidence to support that we should be conducting prophylaxis for critically ill patients for venous thromboembolism prophylaxis. But if one looks at some of the work that Deborah Cook out of McMaster University has done, as of a few years ago, around 15% of Canadian ICU patients do not receive any form of venous thromboembolism prophylaxis. And at that point, we felt that around 3/4 did not receive the most effective form. So in a very simple concept, more is better. The opposite would be overuse. And that's when science shows an intervention is ineffective or harmful, but yet it's used. And I think my sister-in-law's care is a really nice example. So hydroxyethyl starch products have been now evaluated in multiple randomized controlled trials in critically ill patients. We have no evidence that they're helpful beyond sort of transient increases in blood pressure. And we have signals that they might be harmful, and yet they're clearly still prescribed. And so based on the current evidence, really, we would want to favor sort of less is better than more. And the last category is misuse. And this is probably a misnomer, but I can't think of a better term. And that's when science shows an intervention is effective, but it ends up being used for the wrong patients, wrong reason, or wrong time. And albumin, a blood product, is a really nice example in critical care. So we have some evidence that it's effective for select patients with liver disease. So if we do a large volume paracentesis, if it's spontaneous bacterial peritonitis, maybe hepatorenal syndrome. But we also know from multiple studies that it's relatively ineffective for most patients as a fluid resuscitation product. And in fact, it's even harmful for some potentially who got traumatic brain injury. And yet where I work, and I think many ICU patients receive albumin, while many patients with liver disease do not. So this would be sort of more for some and less for others. And the challenge is, as I'm sure many of you are aware, is that the journey from when we have research that provides a compelling argument for changing patient care practice to the time it actually gets into clinical practice is very long. And the Institute of Medicine sort of estimates this at around 17 years. And we think this happens for a variety of reasons. One, we have limited knowledge how to implement science. We clearly have inefficient dissemination methods. Despite a lot of focus on collaborative initiatives, we still have scientific and clinical communities that operate largely in isolation. And we have inadequate assessment of costs, societal values, and personal preferences that might influence our decision to adopt science. And so there's many examples of this in the literature, but I wanted to share with you one. I'm going to share with you this example for two reasons. So the first is because you'll see in a moment, it actually looks at the concept of adoption and de-adoption. And the second is because this work was done by Dan Niven, whose picture on this slide. He's a former graduate student here at the University of Calgary, who's now one of our faculty members as an assistant professor. And so as part of Dan's PhD, he wanted to do the following. He wanted to evaluate glycemic control in critically ill patients before and after the publication of clinical trials that initially suggested that tight glycemic control reduced mortality. That's the Leuven-1 trial, but subsequently demonstrated it actually increased mortality, the nice sugar trial. Now, for those of you who don't follow this literature, let me briefly summarize it for you. So just at the turn of the century, Greet Vandenberg published a seminal publication in New England Journal of Medicine. It was a single-center randomized control trial. It's large, 1,500 patients. And what it showed is that if you used insulin infusions in the ICU compared to standard care and targeted a very tight glucose range, you actually, for every 29 patients treated, saved one life, right? So very impressive. And then what happened is this was implemented by many ICUs around the world, and people started to notice that they were seeing what they thought was more hypoglycemia in their intensive care units. And so this then resulted in a variety of follow-up studies culminating in the nice sugar trial, which is at the bottom of the slide. And this was a multi-center randomized controlled trial, large, over 6,000 patients. And what they found was the opposite effect, which is that for every 38 patients who were randomized to tight glycemic control, there was one additional death. So that's the literature. So then the question is, well, what happens to patient glycemic control in response to this literature? And the bottom line is actually not a great deal. So let me just briefly orient you to this slide. So the first thing, if you look at the y-axis, that's the proportion of ICU admissions with tight glycemic control. The x-axis is time. And what you can then see is the first dashed line in red is the Lubin-1 trial. The second one is the nice sugar trial. And so what you can see is just prior to publication of Lubin-1, around 15% of critically ill patients had tight glycemic control. And this steadily but slowly increased following publication of that study. And then after publication of nice sugar, which suggested that this practice might be associated with harm, what do we see? Well, we see basically an attenuation of that rise. So people stop adopting tight glycemic control, but they're not de-adopting it. And I share this example with you for a couple of reasons. The first, I want to highlight that you can see that with passive dissemination, we have very little, a very slow practice change. And the second thing is that there may be a differential effect for adopting a new therapy that we think is helpful versus de-adopting a therapy that we now think is ineffective or potentially even harmful. So if passive dissemination is ineffective, what might be effective? Well, Taz Sinaf published a systematic review of knowledge translation in critical care in 2013. And she identified here, these are the most common types of adoption strategies that were used. And I use the word adoption because at this point, the literature is almost entirely focused on how we adopt new science into patient care, new practices into patient care. And it's only recently with initiatives like the Choosing Wisely campaign, there's some interest and focus on de-adopting practices. So you can see that the most common practices are things like education, protocols, organizational change. Which of these actually work? Well, those highlighted in orange, right? So we've got some evidence in critical care that protocols are effective, guidelines, bundles, and checklists. And then those in kind of peach color there, education and reminders, evidence that they're effective when partnered with another intervention. Now that's obviously just critical care. What about the broader area of healthcare? And I just summarized some key findings on this one slide. So what we know is that in general, passive education has a limited impact. So for example, me giving this webinar is unlikely to result in significant clinical change by doing that in and of itself. We know that professional interventions have about a 10% impact and change. For example, reminders. And the closer to the point of care they are, the larger that impact. So for example, having a pharmacist remind the ICU team to use venous thromboembolism prophylaxis at the start of rounds is going to be less effective than having a pharmacist go on rounds with the team and ask about it with each patient. Financial interventions seem to be associated with volume of care. You pay people more, they do more. You pay people less, they do less. There's a growing body of literature on patient or family-directed interventions, suggesting that they may be associated with quality of care. And what's particularly disappointing is that both multifaceted and tailored interventions do not appear to be any better than those that are single component or non-tailored, suggesting that a cookie-cutter approach might be effective as a more standardized or tailored approach. Bottom line is the impact's modest and it's variable. And I think it's important for us to just remember that clinical practice and science evolve, which complicates things. So I kind of like this cartoon to illustrate that. It says, for a short period before the Heimlich, Jake's plumbing technique was widely accepted as the way to clear someone's airway, something we no longer do. So now I want to move into the final piece of this presentation, and I want to just illustrate one example of using science to improve care in a very applied manner in a local experiment. So this is a snapshot of my province of Alberta, where I work. We have a network that's province-wide that helps to coordinate critical care in the province across the different zones and cities. We have 4 million residents, 7 cities, just over 200 adult medical surgical ICU beds, which translates about 5 beds per 100,000 population. And using data that's just 2 or 3 years old now, that translated to hospital costs around $300 million annually. So in 2014, we were tasked with the province to try and conduct a pilot project to evaluate the feasibility of closing evidence care gaps, or gaps between where there is evidence that we should be doing something and where we're actually not doing that. And so as we started to think about that initiative, the first thing we had to figure out is which practices to focus on. Many of you have gone to literature recently will know that if you go to the literature in most areas, it's overwhelming, right? And so which practice to focus on. And then furthermore, to complicate matters, many of you are probably aware there's a growing sort of debate or challenge in the literature that's being discussed, and that's the inconsistency of scientific findings. And this was sort of first probably more recently brought to our attention by John Ioannidis out of Stanford University with a big publication in JAMA in 2005, where he demonstrated that basically around 1 out of every 2 seminal publications in the highest impact journal, when there is a subsequent follow-up study that uses a similar method, similar questions, similar intervention, that about 1 in 2 of those you end up with similar effects. Vinny Prasad out of the East Coast did some similar follow-up work, and then Dan Niven, as part of his PhD work, has had a look at this in critical care and suggesting that once again, very similar effect estimates, that approximately 1 in 2 scientific studies published in our highest clinical impact journals have consistent effects when reevaluated. So something for us to think about very carefully when we think about translating science into patient care. And then on top of that, there's the issue of perspective, right? So my perspective as a scientist is going to be different than that of others. And so when we think about translating science into patient care, we probably want to solicit the perspectives of the patients, their families, providers, decision makers, and the researchers. And I think this cartoon highlights that really nicely, where you've got the fellow on the island who sees the boat off in the distance and raises his hand and shouts, "Boat, I've been saved." And you flip to the other perspective, which is the fellow who's in that tiny little rowboat out in the middle of the ocean. He sees land, and he raises his hand and goes, "Land, I've been saved." So perspective is relevant. And so to address that, what we did is we initially launched a very large prioritization initiative. And I'm going to summarize it just with this one slide, to make sure that we focused on those practices that are likely going to be most impactful. So we did that by bringing together decision makers across the province to brainstorm evidence care gaps, and then to go through a consensus method to identify priorities, and they ended up with 13 priorities. Those are the decision makers. So we then shared those priorities with frontline providers across the province. Just over 1,000 providers, 16 ICUs contributed, and those got whittled down to 9 priorities. And then at the same time, we felt we needed to get patient and family perspectives. And so we did that using a series of focus groups and interviews, and they had 9 priorities. And you can imagine the priorities being identified by decision makers are going to be different than those identified by patients and families. And so what we then needed to do is put those together and have a reconciliation panel that consisted of all those stakeholders, come up with what should be a manageable list of priorities for us to at least initially contemplate. And they did that for us. And so once we had those, what we then needed to do is actually audit care. And that is to make sure that where we think there are gaps, there truly are gaps. And so the y-axis on this slide is percent opportunity for improvement. It's sort of a simplified y-axis. And the x-axis, I've got a variety of practices we audited. There's actually more than 5 there because we went and used the provincial electronic medical record system to do it. And we sort of took the ones that we were able to get easy access to data. And the one there in orange, venous thromboembolism prophylaxis, is the one that we decided to focus on for a couple of reasons. And I'm just going to highlight that here before I then show you our initiative. Why? Because it's just simple, it's routine, so it's something common to all critically ill patients. It's got a really strong scientific basis with the PROTECT trial, one of the largest trials ever conducted in Canada, and in the following the economic analysis of the PROTECT. It has a clinical impact where we're able to show that one form of pharmacological prophylaxis with low molecular weight heparin compared to another form, a traditional form of unfractionated heparin, results in differential clinical impact. No difference in deep vein thrombosis. It seems to be associated with fewer pulmonary emboli, less heparin-induced thrombocytopenia, similar bleeding, and lower costs. And just to show you this is relevant, here are some pictures of some patients from the intensive care unit I work in. We published a little case series a few years ago looking at patients who developed heparin-induced thrombocytopenia, and we used to use heparin in the flushes for arterial catheters. And so what you can see here, this is actually skin necrosis in these patients, proximal as they're being exposed to heparin that's being flushed up their arteries, right? So they're reminding us that there's actually real clinical consequences to these decisions. So what we then needed to do is figure out, well, why the heck aren't we using low molecular weight heparin? And so we did a survey provincially, and we were told that really ICU culture is one of the things. We're kind of dinosaurs. We're slow to change. And at the bottom, you can see insufficient knowledge is one of the other barriers that came through. We asked people, what are some strategies we could use to improve venous thromboembolism prophylaxis? Well, they said education, which is interesting given I just presented to you earlier that this is actually probably one of the least effective strategies. They wanted us to use preset orders, some verbal reminders, things along those lines. And so with that, we then came to building an intervention. And based on the data I've showed you, this is what the intervention should look like, right? We've got no evidence that a multifaceted intervention is going to be any better than a single component intervention. But I'll be honest, my confidence in being able to hit the bullseye with a single arrow is not that high. And so we used this approach instead. We felt that we were unlikely to cause harm by using multi-component intervention. And therefore, if we fired a ton of things at the system, one of them was hopefully going to move things along. And our intervention really consisted of 5 components. We built a new guideline. We actually had an old one, but we updated the guideline. We have computerized order entry, so we created a computerized order entry set. We did an educational initiative in Blitz. We launched point of care reminders and then some audited feedback. I'm going to just share one slide around each of these 5 components to give you a flavor of what this looks like and how simple it is. So this is sort of a schematic of our guideline, simplified, very basic. We basically ask clinicians to think, is your patient at high risk of bleeding? If yes, they should get mechanical prophylaxis and be reassessed daily. They shouldn't be getting pharmacological prophylaxis. If they're not at high risk of bleeding, then we should use the most effective forms, right? So we use pharmacological prophylaxis, and there's a couple of different forms based on the literature for different patient populations. We then developed computerized order entry, and this is just a screenshot from it, where we highlight, mechanical prophylaxis is only for those patients at high risk of bleeding. There's adjustments for patients with renal failure because low molecular heparin is excreted partially through the kidneys, and adjustments for different body sizes. We had education initiative. In addition to me giving some rounds, we had a variety of tailored educational products that were developed. We launched point of care reminders, and so we actually would send text messages to our critical care fellows during rounds saying, things basically asking, can you use low molecular heparin for this patient, right? We noticed they're not on it. We asked our pharmacists to review medications on rounds and to explicitly ask the question, is there a reason why we can't use low molecular heparin for this patient? And we tried to engage nurses in this with the individuals who actually administered the venous thromboembolism prophylaxis. And while the nurses were quite keen to participate, management was less keen and felt that this may be outside of the scope of their practice. Therefore, we were unsuccessful in that. And this actually kind of nicely highlights the fact that as we do knowledge translation for interprofessional teams, but there may be some challenges to that or some nuances that we need to think about. We audited the practice and shared it with the unit directors as well as the providers, and this is an example of 4 of the ICUs in the city of Calgary, where you can see in orange that's the y-axis is percent of patient days, x-axis are the ICUs. You can see that actually, because patients can receive more than one form of venous thromboembolism prophylaxis, the stacked bar plots sum to more than 100%. But you can see in November of 2016, in ICU-A, basically 61% of patients were getting low molecular heparin, 8% unfractionated. Almost, over 1 in 4 patients were on nothing, or started getting mechanical. So the question is, do they really have contraindications? And just under 1 in 10 patients are receiving no prophylaxis. And then we gave prizes because this is a research project and it's low budget. These are literally the prizes that we gave, where I would bake at home, as well as the research coordinators would help with that. And this is sort of a sample of the data. So this is the y-axis here is the percent of patient days with thromboprophylaxis administered. X-axis is time. The top bar, the green, is the use of low molecular weight heparin, and the red is unfractionated heparin. And so you can see that in early 2016, we sort of had a baseline that looks pretty stable around basically 50% of patients receiving low molecular weight heparin, 30% of patients receiving unfractionated heparin. And then there's a series there of arrows there as you go across to the right side of your screen that show the different interventions being rolled out. And And you can see sort of a steady uptick in the use of low molecular heparin, a decrease in the use of unfractionated heparin, such that we had about a 20% absolute increased use in the guideline concordant therapy over this period of time. And then so that was our intervention, but we needed to conduct a process evaluation as part of a KT initiative. This is a complex intervention. And really the question we wanted to know is the intervention actually reaching the target audiences? How is it being received? And what modifications can we make to improve? And I'm just going to show you sort of one snippet from that. So one of our hypotheses was that because low molecular heparin is renally excreted, that maybe there was a hesitancy to use it in patients with renal insufficiency. And so that's what I'm showing you here. Y-axis, once again, is percent of patient days. On the left-hand side of your screen, those are patients with GFR greater than 30, so relatively preserved kidney function. And you can see that even before we launched our intervention in orange there, the majority of patients were actually getting low molecular heparin, and that modestly increased following our intervention. On the right-hand side of your screen, with a GFR less than 30, these are patients who have got some renal insufficiency. So you can see that while we've markedly increased the use of low molecular heparin in those patients, there's still a big opportunity for improvement, with about 40% of them still receiving unfractionated heparin. And so for next steps, what I've shown you is if you think back to that knowledge to action cycle, I've shown you that we've affected a process change, right? But I haven't shown you anything about the outcomes. And so that's data, that's what we're working on right now, is sort of linking our patient population to other databases to assess outcomes as well as costs. And that'll be done over the summer and fall. We also want to look for unintended consequences. So we targeted patients that had medical surgical problems, for which we have very strong evidence to suggest that the use of low molecular heparin may be the preferred form of venous thromboembolism prophylaxis. We excluded patients with neuroscience problems, for example, because the evidence is much weaker there. And so we want to have a look, for example, at those patient populations which are treated in the exact same geographical locations to make sure we haven't changed their practice and caused any unintended consequences. We ran this intervention for a year, so we've stopped now, and now we're going to follow for sustainability as well. And as you can see, this has obviously been very labor intensive. And so what we want to do is determine if we can automate the process somewhat to make it a little bit easier to roll out. And so from my perspective, I think there's 3 lessons that I've learned that I want to share with you. The first is that I think it's important for us to remember that research can impact practice through discovery, replacement, and reversal. Many of us think of it only as sort of a discovery arm, but there's 3 arms there to think about. The second is, as we're trying to affect change in clinical practice, patients, families, providers, and decision makers are, from my perspective and experience, very keen to participate in practice change when engaged at the beginning of the process. And the last thing, which we just very briefly touched upon, but I want to sort of highlight, because I think it's important, and that's that if we're going to focus on knowledge translation and getting science into patient care, we should focus on technologies or practices with reproducible evidence. Things that we feel pretty confident are unlikely to change in the near term. In terms of persistent questions, it's still unclear to me when we should adopt or de-adopt a patient care practice. Is that influenced by the magnitude of benefit of harm, the nature of the science, or the cost, or a combination of all those? And so when I just sort of briefly return to our case here and thinking about how care could be improved for my sister-in-law, I mean, the first thing that jumps out at me is that there's a failure to recognize how sick she was and to respond. And so maybe there needs to be a mechanism for family-initiated rescue that can be done. Can you call 911 when you're in hospital? I know that concept may sound kind of preposterous, but it does highlight a potential liability we have in our system. The second one, which is what we talked about for the last 20 to 30 minutes, and that's to find mechanisms to effectively de-adopt harmful and low-value practices, as well as adopt those that are effective. And then lastly, I think it highlights the importance of partnering with patients and their families to not only provide patient and family-centered care, but if we partner with them, we're also going to certainly provide them with probably more technically adept care as well. For those of you that are interested in this area, this is a really nice book by Sharon Strauss, Jacqueline Tetreault, and Ian Graham. Very readable, Knowledge Translation in Healthcare. I want to acknowledge the mentors I have, the collaborators who worked on this project, the trainees, the research team who's actually done the work, and the funding agencies. And I want to finish off by leaving you with this cartoon, which I like a lot. There's a fellow in the middle there with a lab coat, and he says, "My friends, as a result of our experimentation, we have just lost a dear and valued colleague. On the other hand, we've just gained a publication. And I highlight this because this cartoon, I think, is the antithesis of knowledge translation. The whole reason we're doing all this research is to translate into better patient care. So thank you.
Excellent presentation. Thank you, Tom. And I loved your cartoons.
I'm happy to hear that.
They say so much. We have about 10 minutes or so for questions, so I'll turn it over the Q&A to Perry. Go ahead, Perry.
Hi, Tom. Perry Kim here. As we wait for attendees to type in their questions, maybe I'll ask a question of them to sort of start things off. So maybe you could address, what is the relationship between knowledge translation and quality improvement?
Great. Yeah, that's a great question, Perry. I think that the two are closely interlinked, and the way I like to think of it is there's obviously various frameworks for quality. One of the frameworks that I think nicely provides a way of thinking about that relationship is the Institute of Medicine's 6 aims for healthcare. And so they include the fact that care should be, safe, it should be effective, it should be timely, it should be patient-centered. And so I think of it as in terms of the effectiveness issue, right? And so effectiveness is really the concept that we're providing patients with care that represents sort of the highest or the best state of science. And so knowledge translation would be one dimension of quality in terms of targeting that. And then to expand upon that, as I've done this type of work, I'm increasingly convinced that probably from a impact perspective, we might be able to have the largest impact by actually focusing on knowledge translation and in terms of improving the effectiveness of care, because as long as we're focusing on interventions that have been well evaluated, we've got really good science to back that up. Not to say we shouldn't have care that's patient-centered or timely or safe. It should be, absolutely. But I think it provides a very effective aim in terms of improving quality of care.
Okay, thank you. As we wait for more questions to come in, just a question I had that's sort of related to what we do here. We fund a lot of research, mainly clinical research, but one of the things that I always wondered about was, what do you, in your opinion, what do you think the role of the clinician researcher is in terms of disseminating and translating one's research findings? Is there an obligation in your frame of reference in terms of that they should be involved and they should be spearheading these sort of initiatives, or is it purely more sort of their responsibility to publish the research and then disseminate it through sort of the usual ways that one would disseminate research findings?
Yeah, that's a great question, Perry. My feeling is I guess that probably it would be important to figure out where they work and what their funding mechanism is, right? So I think that for the vast majority of us, our research is going to be funded through public sources. And without being aware of the science, my feeling is that the vast majority of the public supports the concept of research because they believe that it's designed to ultimately benefit the public. And if that's the case, then that would suggest that receiving money from a public source would result in a responsibility to then disseminate that to the public, back to the public. And obviously, that can be done in a variety of ways. That can be done, as I illustrated, in a passive way, which is going to result in very slow diffusion and very little impact, or in a more active way, which will hopefully accelerate that. And so I think that it's the scientist's responsibility to do that, whether they're the ones that do it or whether they partner with individuals who have expertise in that. That could be sort of up to the scientist. But no, I think that if the money is coming from a public source, then we need to make sure it's broadly available and disseminated.
Great. Thank you for that, Tom. One of the questions we have is by Shirley Meyer. The question is, are there certain basics that should be in place prior to making a change?
So are there certain basics that should be in place prior to making a change? So I guess I'll take the liberty of interpreting that question as follows. So, what would be the landscape? So I would say yes. I would say that that if we would want to, one, be confident in the science. That would be the number one thing. And actually, I'm going to take a moment to just sort of expand on that. From my perspective, one of the biggest risks we do with knowledge translation is if we work to implement practice change for things that we lack confidence in. And the reason that's potentially so dangerous is because, one, okay, we could implement something that's going to be harmful, right? And the tight glycemic control example is a really nice one. So that's going to be a big problem. Two, it's a huge opportunity cost because we could be spending that energy on other initiatives that might be more effective. But the third one is the one that worries me the most, and that is that from a clinical perspective, I think if we want to disengage clinicians from knowledge translation, the best way to do it is to launch initiatives around a practice change that we are then going to reverse in the near future, because it then sort of reflects what I frequently hear, which is that we're chasing shiny objects and that this is the initiative for this year and next year it's something totally different. Recognizing science is going to constantly evolve, absolutely. So what we do in 30 years from now might be quite different than what we do right now, but we're better off focusing on things that are likely to have impact and to have some durability, at least in the near to intermediate term. So that would be the first thing. That's a long answer. And then I think we could think about the other elements of that knowledge to action cycle, which I won't go through, but thinking about how we then think of what baseline circumstances we want to have before we launch an initiative.
Thanks for that long answer, Tom. Very appreciate it. Curious, with that answer, the first part of your answer sort of brought to mind a phrase that I often hear, at least when I'm sort of listening to news reports and other things, which is that medicine is more of an art than a science. And I don't know if you know the answer to this, but do you think that phrase comes from the fact that, again, some of the things that clinicians might do in their daily practice may not be purely solely evidence-based?
Yes, yeah, that's a tough question. So I think what I would say is that that phrase probably originated before our current state of science. Be the first thing. I think the second thing would be that I think we have to recognize that everything we do in medicine has actually been informed by science, whether we recognize that or not. But the clinical exam we do is essentially emerged from various forms of science, and there are various degrees of different methods that have been used. So I think it's all been informed by science to various degrees. Obviously, at this point, we still need a human to interpret all the information in medicine and to come up with good rational decision-making around patient care. And that's probably where, in some ways, the art comes in. But I think the flip of it, we have to be very careful to recognize that as humans, our cognition limits our ability to recognize many of the inherent heuristic biases we have. And so we need to have science to supplement the clinical decision that we make. It shouldn't replace it, as David Sackett nicely illustrated in his BMJ article. We need to both have the clinical decision making, but we also need to have the science to inform our decision making.
Right. Just as a side note, in the question and comment section, Alan Garland, one of our research management committee members, wrote in that he has a response to my statement, which is that no, medicine is not an art. Rather, it's an incompletely understood science, which I believe is very close to what you were saying.
No, I think it's a reasonable way it's a very reasonable way to interpret it. Absolutely.
Right. Okay. Well, one last question, and that is from Mohammed Mullah. The question is, you mentioned how 50% of papers in high-impact journals are not reproduced. As a result, how must clinicians respond to new evidence?
Sorry, I missed the last part of the question.
Okay, sorry, I'll reread that. You mentioned how 50% of papers in high-impact journals are not reproduced. As a result, how must clinicians respond to new evidence, or how should they respond?
Okay, thank you. I appreciate that. Yeah, so I think that the answer would be carefully. So I think as humans, we're primed to, and as physicians or healthcare providers, we're primed to sort of enthusiastically adopt new ways of helping our patients. And I think what the lesson that's coming out of the literature is that we need to temper that enthusiasm. And so when we have a new seminal publication that comes out in the New England Journal this coming week, for example, or the Lancet or JAMA or whatever, that suggests there's a new therapy that may benefit our patients, we need to, one, critically appraise that article with a skeptical eye, because we want to be skeptical around these things so that we subject them to a robust evaluation. And then we need to think about whether or not that's ready for prime time or not. And that's not a simple answer. I don't think we have an answer to know when it's ready for prime time. But what things we should be thinking about is, what are the risks of bias in the study? Is this been done in more than one center? How large is the patient population? At least thinking about the internal validity of the study. And then obviously we can think about how it applies to our patient population. And I think that, to be honest, these decisions would be best made at a collective level as opposed to an individual physician level in terms of when therapies are ready for prime time. And by that I mean a practice group or a hospital group. So to temper our enthusiasm for jumping into new interventions that really need further evaluation. And I would suggest that the first reports of an effective intervention should be greeted with a lot of enthusiasm for us now going and testing them again, as opposed to implementing them right away.
Okay. Thanks again, Tom. Those were great questions and some great answers. And I'll have to thank everyone for sending in questions today. And some of you have called in or sent emails in saying they missed some of the questions. And just a reminder that we will be posting both the slides and the webinar within 1 to 2 days. So you're welcome to listen again to this presentation and Q&A. We hope you can join us for our next webinar, which is July 12th. And so that concludes today's webinar. I hope everyone has a great rest of the day. And again, thank you, Tom. And it was just a great presentation. And bye for now. Thank you.
Thank you.